on physical exam for his knee, he had Osgood-Schlatter's as a kid, and but that didn't really seem to bother him much anymore. The patellar tendon was not really tender to palpation. The tibial tuberosity, where the patellar tendon is going to attach, and where you get Osgood-Schlatter's, is no longer tender to palpation. So we didn't really think that we were going to do anything in regards to the patellar tendon. The physical exam showed that most of his pain was likely coming from chondromalacia patella, which is where the underside of the kneecap, where there's cartilage, there can be some inflammation and a little bit of degeneration. And then some saphenous nerve involvement. And so we hydrodissected the saphenous nerve and treated that. We then treated inside the knee joint to bathe the cartilage on the backside of the patella. And then I went to go treat the infrapatellar fat pad, just because I'm such a huge believer in the infrapatellar fat pad contributing to the healing of joints, or the knee joint specifically. That when we scanned his patellar tendon, he actually had a pretty significant tear in his patellar tendon. Now, at this point, we have to step back to understand that maybe this is not painful for him, because again, our physical exam didn't really suggest that the patellar tendon was involved in his pain. However, we also have to understand that sometimes the physical exam might mislead us. Sometimes in really athletic patients, we might not get the full picture because the tissues are so used to being moved, manipulated, things like that, that we don't always elicit pain from certain structures. And we also have to think about the long-term aspect. So if you have a large tear in a tendon, that tendon is going to be compromised, obviously. And over time, that could progress to where it becomes painful, or where it could result in a further tear that could be problematic. And so because of that, we made a game time decision with the patient to add in and inject the patellar tendon with PRP inside that tear to hopefully help that tear heal, which I'll be excited to follow that and track that. And interestingly, when we did those injections into that, it did create some familiar pain for the patient. Again, going back to the earlier discussion of recreating patients' pain, this was important for us because it was something that didn't show in the physical exam. And if I didn't do ultrasound guidance for my imaging for my injections, then I wouldn't have known that this tear was there, because it also did not show up on his MRI, which is rather interesting because it was a pretty significant tear. But that is what we ended up doing with him. We put a little bit extra PRP and some BPC into that tear to try and help that heal.